Welcome back to Body Gears Masterclass. Again, my name is Bob LeBeau.
I'm Rebecca Johnson.
So right now we're going to go through a basic lower quarter screen. The last module is on upper quarter. So if you're having problems with patient with problems with the shoulder, elbow, neck, or thoracic spine, you do an upper quarter screen. If you have problems with anywhere from the belly button below, we do a lower body screen. Again, the purpose of the screen is just to make sure you're not missing anything and kind of highlight where we're examining. We're going to add a little more examination specific tests. So we're going to go through in somewhat real time. So you always want to make sure you assess the patient in real time. You want to ask them, hey, how are you doing? If they have extension sensitivity or flexion sensitivity, you don't want to blow past that. You want to go slow and easy. You want to make sure the patient's comfortable. Again, soft, gentle hands, go easy. Make sure the patient knows what you're doing so you know the patient is comfortable and going to give you the best examination possible. So for a lumbar screen, I'll go ahead and face that way. Oftentimes I'll look at flexion. So let's step back, just look at something in the camera. Perfect. You want to make sure they're not bumping up into tables. That happens all the time. But I'll have you just flex forward and try to touch your fingertips to the floor. So Rebecca's got good range of motion. She's able to get almost down there. So we're going to say, any discomfort there?
No.
So I'm going to bring my hip and just kind of grab onto the opposite hip and go ahead and flex your head down. Now we'll look at a dural tension. And if that's okay, you can also put a little extra pressure through the lumbar spine. Come on back up. Sometimes it'll just aid a little bit and help the patient come up more comfortably. So for extension, go ahead and cross, put your hands on the small of your waist there, and go backwards. Any trouble with that?
Mm-hmm.
Excellent. So you look at quality of movement, apprehension to movement, range of motion really. So for extension with overpressure, I'm going to have you cross the arms here. I'm going to come and hold onto the shoulder, and this hand is sort of going to, I'm going to move this a little bit. This hand is going to kind of block the spine. My legs are wide, and my head is going to just guide that motion. We're going to go, and the patient's head could rest on mine. We're just going to go back as far as you can comfortably and assess the value of motion and range, quality, and discomfort, pain provocation. So after we look at flexion and extension, we could look at side flexion. So face the camera there. So hands onto the side of your hips. And we side flex down. Go down as far as you can. And we can measure from a tape measure from fingertips to the floor and to just get some type of objective measurement. We do the same with fingertips to the floor and flexion. How many inches are the fingertips to the floor? It's just nice, easy to evaluate. So, an extension quadrant, if we don't have any problems here, cross your arms. So before we go on to the quadrants, we can have our side flex. So if we side flex, I'm going to bring my hand here and I'm going to bracket the hip and give her a little extra pressure. So I'm side flexing her away and giving her extra side bend pressure to really see if the facets are closing down, the ribs are causing some problems in the lower thoracic, if the disc is giving some issues on the lateral side. Now extension quadrant, let's go here. Move it to the side there. Perfect. With this one, maybe move just a little bit more. Good. Fortunately in clinical practice you don't have to move so much. You want to have a width, the feet width about a foot width apart. That way it's consistent each time. The patient's arms are crossed. I'm going to grab the front of the hip with my bottom hand, my hand to the front, so that way I could side flex. I'm side flexing the patient toward me. I'm going to grab onto the shoulder and rotate and extend. So the whole idea of a quadrant is a combination of three movements. I tend to leave extension for the last one because it's most provocative. So again, I have a very good base of support. I have very good control of the patient. They feel comfortable, so we're going to side flex, rotate, and extend. Let me see, does that cause any problems? So this is really jamming up the facets there, maybe a little disc impingement. We're not quite sure, but we want to see if this is some part of the quadrant we want to look at more closely with examination. So we do the same on the other side. Go ahead and turn yourself. Now opposite of extension quadrant would be flexion quadrant. So I would go ahead and have the patient flex forward, and I'm going to ask them, hang on one second, is it okay if I reach across and grab your shoulder during this exam? If you don't ask them, they get a little apprehensive. Then step back just a little bit. Perfect. So I have you flex forward. Good. I'm going to take my hip and block her opposite side. I'm going to hold onto her hip very easily from this side. So my hip is pressed against her hip on this side. my hand on the opposite side. So she has comfort that she's not going to be toppled over or off balance. I'm going to reach my hand, so this is flexion. We're going to do rotation next, quadrant rotation, and side flexion. Good. And come on back. So a lot of soft tissues might be under stress. If they have a disc involvement, you may get a positive sign with that one. So we have extension quadrant, we have flexion quadrant, doing them in both directions after extension, flexion, and side flexion. Now, rotation is another movement you can do if you wish, but you have to differentiate as the hip, pelvis, or lumbar spine. In this screen, I'm just going through more of a general look, so I'll probably omit that for later if I have to cue in on more significant pathology causing rotation. The combined movements of side bending and rotation in the quadrant tells me a little bit more. So next I we're next going to do a little functional movements. So just go up on your tiptoes, walk on that. This is a little bit of a myotomal screen here. Good. And let's go on. You want to do that for about 10 or 15 seconds to test endurance. And then walk on the heels. So you want to look at the S1, S2, you want to look at L4, L5, just to see the competence of the nerves down in that lower quarter. Have a seat there. Again, you got to be patient at the edge of a table, it makes it easier. So we're going to look at hip flexion. This tells me a lot about core activation. Of course, in a patient view, you might want to have the t-shirt tucked up to really look at the muscle recruitment pattern. You put your hands to the side there. You can scoot over just a little bit. So I want to give them a stable base from which to act on. So I have them flex their leg up. So I want to see quality of movement. Do they rotate a lot? Is the core working well? The psoas is a huge connector to the lower back, so I'm going to have a test for psoas. This is a manual muscle test, but really I'm looking at core engagement. Hold there. Does she have automatic core engagement? Does she have endurance? Does she have strength? Strength and endurance. Strength first. Flex this one up. If she doesn't have strength, she doesn't have endurance. So we see on Rebecca here, she's not pivoting too much. She has pretty good control of the core. So slide back. Now if you want to, you could always add your myotomes here for the lower quarter. Easy to add in. But you can also look at sensation if you're suspecting neural involvement lower. But what I'll do next is a little dural slump if I'm suspecting of disc or back problem. So for the slump, I like to sit next to them, so I have them flex down. First of all, any symptoms, you always want to see what the baseline is. Go ahead and flex down, so we're going to really put a lot of flexion. We want a little head flexion, a little thoracic flexion. You take the opposite the leg closer to you, and you draw it into knee extension and hip flexion to feel how tight that is. You bring the toe into dorsiflexion to see if it reduces their symptoms. Now, if the patient says, yes, that feels awful in my calf, but that's not their normal symptoms, it's really not a positive test. It's just a muscle or nerve length test. And there's some value to that, but if we're trying to reproduce their lumbar symptoms or hip symptoms, if we do a slump, again, flex down, we would do this on both sides. You extend that leg, you have good control of the patient, bring them up into the tension. Now, we could also play around with medially or internally rotating in dorsiflexion or laterally rotating the leg. What that will do is will highlight different branches of the nerve. As Rebecca kindly did, she propped her arms behind your back. That's the proper and efficient way of looking at that. Now, if that's positive or questionable, we can go on to a simple SLR straight leg raise test to continue with our exam screen. So I land back. Now, the reason I'm looking at this is it has good sensitivity to problems in the lower back. If they don't have a problem with it, it's not lower back. Specificity is a little bit different, but it'll give me a good clinical picture. Is it coming from the back? Is it coming from disc issues? So for a straight leg raise, we're looking at just gently comparing one side to the other, bringing them up into hip flexion until they feel the onset of resistance. And you go to the end of resistance and flex the foot down. Now, something I did mention in straight leg raise or slump test is the sensitization. So after you get them into that position, it winds them up. If you flex or extend their head, it might change the symptoms. If flexing their head makes it worse and extending it makes it a little bit better, they might have more of that dural nerve root issue. So as we bring her into just knee extension and hip flexion, bring her into dorsiflexion, ask her any symptoms with that. Again, we can immediately rotate an AD duct or laterally rotate an AB duct to affect different nerve structures. Now, if they do have just a little bit of symptom, but you want to really sensitize the tissue, this is what we call the peripheral sensitizer. This is the more central, the other peripheral sensitizer would be the head. So flex up the head while doing this. This really puts a lot of pull on the nervous system and gets you an idea of where you're having trouble. So again, just to review, this is a basic screen for the lower quarter. We look quickly at myotomes with dorsiflexion and plantar flexion, heel walk and toe walk. We look at a little bit of myotomes again with hip flexion, just to see how the core is reacting. If the core is not functioning properly, there's more tests, more elaborate tests that we can use. But we want to look at range of motion, quality of movement, if their familiar symptoms are reproduced. If they're getting some other symptoms, it might be an artifact, or it might be some other thing that you want to look into. But all these movements will help implicate the spine problems. Now, one last thing here, after you look at the spine, we'll look quickly at the hip, knee, and ankle. Let's go ahead, lay on your back there.
Take socks off.
No, it's fine.
No. Okay.
Generally, you're going to expose the skin, shorts, socks off, shirt elevated, so you really got to look at the spine. Since this is just a training module, we're leaving it on. So hip, you want to look at hip range of motion. We look at flexion with overpressure. We're looking at lateral rotation or external rotation and internal rotation. You could sneak in a quick fader, flexion and adduction, internal rotation, and a Faber there if you're suspecting of the hip pathology. Knee flexion, very simple flexion with overpressure. Put a little pressure here, hold on to the top of the knee, and you're driving it straight back. You could outwardly rotate it and inwardly rotate it to really stress that tissue. Again, to see if you need to do more specific examination. Knee extension, hand goes above the patella, not on the patella. You bring, I'm going to cross over on the side, not so good form, but good for TV. I'm going to push down here with the hand and pull up to get extension. So all tissue, if it's efficient, should allow overpressure without having pain. If it's painful or stiff and limited, it might be dysfunctional. Ankle, very simple, dorsiflexion with overpressure, dorsiflexion with overpressure, plantar flexion with overpressure, inversion, and eversion. If any of those things trigger a concern or reproduce their familiar pain, it's something you want to look into more thoroughly. And again, we'll go through all the extremity joints and spine joints in further modules. Thank you very much.